Riya's joining.
Hi. Hi, Ria. It's just the three of us.
She's on mute.
Hi, Ria. It's just the three of us.
She's on mute. Why can I hear this again?
Yeah. All right, I think I'll start.
Yeah.
Malaria is a protozoan disease and is caused by the bite of the infected Anopheles mosquito. So if you all remember microbiology that we did last year, the parasites, human parasites can either be unicellular protozoans or they can be multicellular helminths. And out of the protozoans, you had like amoebae, flagellates, ciliates, and sporozoa. So our plasmodium belongs to sporozoa and Euphoxidea subclass. Now we have the genus Plasmodium and four important and one recently discovered species, Falciparum, Vivax, Malaria, Oval, and Knowles. Out of which Falciparum causes all deaths and is the most severe of all. And why it is the most severe is also what we will be discussing in like ahead. However, Vivax is the one which is the widest, which has the widest geographic distribution throughout the world. Now, in India, unfortunately, we have 50% of the cases that are falciparum. 4 to 8% of them are mixed, and the rest of them are Vivax. So, the life cycle of the Plasmodium gene, the parasite, which is a protozoan, takes place in two hosts. It has an intermediate host where the asexual cycle takes place, which is man, and the definitive host where the sexual cycle takes place, which is the Anopheles mosquito. So we need to know a few points about the etymology of the mosquito. So basically, because it is an invertebrate and it has an exoskeleton and it has paired jointed appendages, it belongs to phylum Arthropoda, which we had done in like class 8 or 9, which has three medically important classes: Insecta, Arachnida, and Crustacea. And like we have all of this in entomology, but I've taken only the one where our mosquito belongs, which is class Insecta, because its body is divided into a head, thorax, abdomen. It has three pairs of legs, one pair of antennae, and 1 to 2 pair of wings. Now, other insects include flies, lice, fleas, and the radioid bug. But obviously, we are interested in mosquitoes, which can either belong to tribe Anophelinae or tribe Culicinae. So, tribe Anophelinae only contains the genus Anopheles, which we are interested in, whereas Culex, Aedes, and Mansonae belong to tribe Culicinae. And there are particular differences between these tribes with respect to their life cycle, which we'll be seeing ahead. Now, the important species of Anopheles. What we did earlier was the species of the protozoan parasite, Plasmodium, which causes malaria, and this is a vector of malaria. These are the important species, and this is given in parks, so I think we should know this. The most important over here is obviously Culicifaces, which is seen more in urban, in peri-urban and rural areas, and Stephensii, which is responsible for malaria in urban and industrial areas like Mumbai. And I think the overall most common one and the most popular one is Stephensii. Apart from that, you have Fluviatilis, which is found in the hilly areas and forest regions, Minimus, Anopheles minimus, which is found in the foothills of Northeast, Anopheles dirus, which is found in the forests of Northeast, and Epiroticus, which is found in the Andaman and Nicobar. So they've given this description of the body of a mosquito, and I kind of like drew it because it was so easy and like it just seemed very difficult to understand. So basically, the body is divided into the head, thorax, abdomen. The head consists of a pair of compound eyes, a proboscis, a pair of palpi on either side of the proboscis, and a pair of antennae, which are bushy in males and not bushy in females. And that's how you differentiate between male and female mosquitoes. Now, the thorax dorsally contains basically contains a pair of wings and three pairs of legs. And on the posterior border of the wings, there are fringes of scales like we're seeing here. Abdomen is divided into 10 abdominal segments, and the 9th and 10th segments are modified to form external genitalia. Now, the life cycle is it's kind of important, and this is the difference I was mentioning about between the two tribes of mosquitoes, Anopheles and Culicinae. So basically, the eggs are laid on the surface of the water, about 200 to 250 at a time, and tribe Anopheles lays them singly. The eggs are boat-shaped and they are provided with lateral floats. After which, within 1 to 2 days, they develop into larvae, which are free-swimming, and they feed on algae and bacteria, and they undergo 4 stages of growth, which are known as instars. So the larvae, in case of Anopheles, they rest parallel to the water surface, whereas in the other tribe, they are suspended with the head downwards at an angle to the surface of the water. Also, the larvae have no siphon tube in Anopheles, and there are palmate hairs present on the abdominal segment. Now, the pupae in case of Anopheles, the siphon tube is broad and short. These are basically comma-shaped structures with the cephalothorax and the narrow abdomen. So the head and the thorax haven't separated yet. And this is known as the resting state. And within 1 to 2 days, again, you have an adult, which when it rests, it inclines at an angle to the surface. The wings are spotted and the palpi are long in both the sexes, whereas in Culicinae, the palpi are short in the female. So these are the basic differences. Now, this is the life cycle that we were talking about. The egg, which in 1 to 2 days develops into larvae, in 5 to 7 days develops into a pupa, which is the resting state, after which it develops into an adult. Now, the adult basically has its own life cycle or a feeding cycle, which consists of seeking for a host to have a blood meal, which is in the case of a female, because males never bite, they feed in plant exudates, but the females are hematophagous, that is, they have a blood meal. So they seek for a host and they go, they bite, and then they rest. Depending on the resting habits, they are said to exhibit either exophily or endophily. Endophily means they rest indoors on the walls of the houses after their blood meals, and that is basically the concept behind indoor residual spray. Now, when the blood meal can either be taken of animals or of humans, and if it's taken in humans, it's called anthrophilic mosquito, and if it's more prone to taking animal blood, then it's called a zoophilic. So an example of a highly anthrophilic mosquito is the Anopheles fluviatilis. Now, the male and the female, first of all, after that, they undergo breeding, and then there's fertilization, and the female lays eggs after that. Now, the breeding habits of Anophelines and Culicines. So, Anophelines are they tend to breed mainly in clean water, whereas Culicines tend to breed in dirty, polluted water. And Anopheles, even among the Anopheles, Fluviatilis tends to breed in moving water. Sundacus tends to breed in brackish water, and Stephensii, which is more popular in the urban areas, like we discussed, breeds in wells, cisterns, and overhead tanks. Now, the overall life cycle is of about 10 to 12 days. Now, from the time that a female takes a blood meal till the time that she lays eggs, this time is known as the gonotrophic cycle. Now, the reason why we discussed about zoophilic and anthrophilic mosquitoes is because there is this index, which is called the human blood index, which is the proportion of the freshly fed female mosquitoes whose stomach contains human blood, which I don't know how they measure. But this shows the degree of anthrophilism. Like we said, that Anopheles fluviatilis is more anthrophilic. Also, the blood meal, the time of the mosquito taking the blood meal also varies. Mostly, the blood meal is taken at night, except for the Aedes mosquito, which obviously doesn't cause malaria. Now, coming to the anti-larval measures, they can either be environmental. So these are basically our integrated vector control measures. Anti-larval measures can either be environmental, where you don't allow water to accumulate because you know these are breeding in water. And they can be chemical measures where you use temifos or abate. And they can be biological measures like the use of larvivorous fish. Also, insecticide-treated bed nets and long-lasting insecticide nets, which obviously will prevent the mosquito from taking a blood meal. This was asked as an SAQ, and the answer is nowhere given in PARC. So I kind of like, so there are guidelines for this, and they have, so then I was sincere enough to look up the guidelines. So anyways, the insecticide-treated bed nets, they reduce the man-vector contact, and they are usually used for synthetic nets, not for cotton nets. Okay, so they're used for nylon or polyester. Also, they are not harmful to people if you like tend to touch the insecticide or anything. Also, like the procedure for treating the net is you collect the necessary equipment and then you put on protective gloves, and then you measure the correct amount of water, which is approximately like half a liter per net. Then you measure the insecticide, which is usually given like on the packet, whether it could be malathion, parathion, etc. And then you mix the water, insecticide, you put the net, you soak it. Then you dry it first. First of all, you never dry it in sun. So you always dry it indirectly under shade. Secondly, first you half dry it kind of like on a hard surface, which is obviously the surface that does not absorb the insecticide. And then once it's half dried, you hang it in air. So that now basically when you tend to wash this bed net, obviously the insecticide will wear off. And hence the concept of long-lasting insecticide bed nets, where the insecticide does not wear off for up to 20 washes, and you can use it. So in some areas where there is higher incidence of malaria, the government distributes long-lasting insecticide bed nets, and in a village, how do they count the number of bed nets that they're going to give? Is the number of long-lasting insecticide nets is equal to the number of households in the village multiplied by 2.4. So they're basically assuming that one household will need 2.4 bed nets. So that was about the vector, and so we're done with vector control and the life cycle of the vector. Now coming to the most important part, which is the life cycle of the parasite itself. So when this female Anopheles mosquito has a blood meal, the sporozoites will enter man. And according to Park, the incidence is more in males than females because males are more outdoors and less better clothed than females, according to Park. Now, when these sporozoites, they enter humans and they undergo a pre-erythrocytic or exoerythrocytic cycle in the liver. Now, how they enter the liver is by using the receptors for the proteins thrombospondin and properdin. So these are receptors on the hepatocytes for the proteins thrombospondin and properdin, but instead the sporozoites will enter the hepatocytes using the receptors for these proteins. Then they will obviously undergo differentiation and development into the hepatocytes. They will cause swelling and eventually bursting of the hepatocytes, releasing merozoites into the bloodstream. Now, in case of ovale and vivax, the two species, some of the sporozoites will remain dormant inside the hepatocytes, and these forms are known as hypnozoites, and they are responsible for causing a relapse of malaria. Now, as far as sporozoite to merozoite ratio is concerned, one Plasmodium falciparum sporozoite tends to give rise to about 40,000 merozoites, whereas the others, that is ovale, malaria, and vivax, one sporozoite gives rise to about only 2 to 15,000 merozoites. So this is one of the reasons why falciparum is more dangerous than the others. Obviously, we'll see the other reasons soon. Now, once the parasites enter the RBC, and how they enter is also important, but once they enter, they do not re-invade the liver. And I'll tell you why this point is important. Now, first of all, the merozoites attach to the RBCs via surface receptors. So there are proper specific surface receptors which the merozoites use. For example, the Plasmodium vivax merozoite uses the Duffy surface antigen. Now, if you remember, Duffy is the type of blood group antigen, and hence any individual who is Duffy negative will not have that surface antigen and will be refractory, or we can say resistant to Plasmodium vivax. So he will never get a Plasmodium vivax disease. Now, once inside the RBCs, they will undergo what is known as the erythrocytic cycle, which lasts for about 72 hours in Plasmodium malaria and about 48 hours in others. Now, this erythrocytic cycle in the RBCs is responsible for the clinical illness. And what we see in humans in the peripheral blood is that it undergoes differentiation inside the RBCs. You see trophozoite or ring forms, you see schizons, which are amoeboid forms. And again, the schizont will cause the RBCs to swell, it will use up all the material, and the RBCs will burst, releasing merozoites. Now, some of these schizons will also develop into sexual forms, which are the microgametocyte and the macrogametocyte. So when you collect blood from a human being peripherally, what you are going to see essentially are the trophozoites, schizons, and the gametocytes and the microgametocytes. All right. Now, any person who has the macrogametocyte and the microgametocyte in his blood is capable of transmitting the disease to others, because when a mosquito bites this person, the micro and the macrogametocyte will go inside the mosquito, and then the life cycle takes place inside the mosquito, which is the vector. So basically the microgamete and macrogamete fuse, they form the zygote in the midgut, then they form the ookinete, which develops into the oocyst, and this oocyst bursts, releasing many sporozoites into the entire body cavity, but some of them get concentrated into the salivary glands, and when this mosquito bites another man again, it will be transmitted. All right. Now, talking about the bite of the female mosquito, these mosquitoes thrive in a temperature of about 20 to 30 degrees, and when there is a relative humidity of 60%. And usually these are not found above a level of 2,000 to 2,500 meters. So those altitudes you don't tend to find Anopheles mosquitoes. Also, the time taken for a mosquito to take a blood meal and the microgamete and macrogamete to fuse and then ultimately form a sporozoite, where a mosquito then is capable of transmitting the infection to others. This time period is of about 10 to 20 days, and this is what is known as the extrinsic incubation period of malaria, which is the life cycle of the plasmodium inside the vector. Now, talking about a human who contains the macrogametocyte and microgametocyte, he will be known as a human reservoir, because he is capable of he's kind of storing the infection for other humans to carry forward. So that's what you call a human reservoir. Children tend to be more like the probability of a child being a reservoir is much more than that of an adult. And there are certain criteria that you need to fulfill to become a reservoir. So the first criteria is you should have both sexes of the gametocyte, both micro and macro, which must be mature. So once the schizons burst and they release merozoites, it takes about 2 to 4 days for these gametocytes to mature. The next is they should be viable. So if you're giving gametocidal drugs like primaquine, then obviously this human will not be able to transmit the infection. And secondly, they should be of sufficient density, which is approximately assumed to be 12 per cubic millimeters of blood. Now, certain important points over here are that, firstly, why was this point important, that the parasites entering the RBCs do not re-invade the liver, is malaria is also capable of being transmitted through blood transfusion or when drug IV users are sharing needles, etc. And in that case, you don't have the pre-erythrocytic or the exoerythrocytic cycle taking place. So what is transmitted via the blood or the organ transplantation is, or drug IV route, are the erythrocytic forms like the trophozoites, etc. And hence you don't need to give drugs like primaquine, which are actually the tissue schizonticides, which act on the pre-erythrocytic or the exoerythrocytic cycle. So you don't need to give radical treatment for the malaria that is not caused by mosquito. Also, like they ask this MCQ, that which is the infective form of the parasite, it's obviously the sporozoites, because they enter the man and infect via the vector. Now, the incubation period in humans, not the extrinsic incubation period, the incubation period in humans is from the time that a mosquito bites a human, that is from the time he is infected with sporozoites, till the time he shows clinical illness because of the erythrocytic cycle. And it varies with the form. So in Plasmodium falciparum, it lasts for 12 days. For Vivax, it is 14 days. For malaria, it's 28 days. And for ovale, it's 17 days. So we've done quite a bit quite a few dates. We did this gonotrophic cycle, which is the time from which which is the time from which a female mosquito has a blood meal to the time she oviposits. Next, we did the extrinsic incubation period, which is the life cycle of the parasite in the vector, which is the mosquito, which is about 10 to 20 days. And the incubation period in humans, which is from the time that a human is infected with sporozoites till the time that he shows a clinical illness because of the erythrocytic cycle, which varies with each species. Now, depending on all of this information, we use all of this for what is known as the measurement of malaria. What is the extent of malaria? I've already discussed human blood index, which is the proportion of freshly fed female anopheles which contain human blood in their stomach. The next is sporozoite rate, which is obvious. It's pretty obvious. The number of sporozoites, the percentage of female anopheles with sporozoites in their salivary glands. The next is mosquito density. It's again quite self-explanatory. The number of mosquitoes per man-hour catch. Now, what is this concept of a man-hour catch? Is that suppose it's me and my friend, so it's two people, and we look for mosquitoes for 2 hours. Then the man-hour catch becomes 2 into 2, which is 4. So 2 men looking for 2 hours. And and suppose the 2 of us manage to find 1 mosquito, then the mosquito density becomes 1 mosquito per 4 man-hour catch. So that is the basic idea of mosquito density. Man biting rate is the average incidence of Anopheles bites per day. And inoculation rate, basically what the mosquito is inoculating into your blood is sporozoids. So inoculation rate becomes how much inoculation is occurring. So how many times the mosquito bites you, that is the man biting rate, multiplied by how many sporozoids it is biting, which is the sporozoid rate. So inoculation rate is nothing but a combination of sporozoid rate and the man biting. I hope it's clear so far, so we can go ahead. Can you all like tell if we're going fine and should I continue?
Yes, you can continue.
Okay, everyone's just saying hi. Hi, everyone.
Yes, you can continue. It's fine.
Continue. It's really good.
Right. So, like I discussed, these are the forms that we see on peripheral blood smear, and so these are the forms that we see on a peripheral blood smear. So, the trophozoid or the ring forms, which are single chromatin mass, and schizons, which are multiple chromatin masses. Now, in case of Plasmodium falciparum, what I have drawn is just a trophozoid. But in case you see multiple ring forms on the periphery of the RBC, it's known as an occult form. Now, when the schizont, it contains merozoites, and when it grows immensely, then it will burst, releasing merozoites into the bloodstream. Now, usually you don't find falciparum schizons into the peripheral blood smear. Also, if you all have noticed, the Vivax RBC is extremely enlarged, because of which when you're making a peripheral blood smear, which we'll discuss how it's to be made, but when you're making it, these RBCs tend to get concentrated more on the leading edge of the slide. So and hence it does not give us a very accurate measure of the Vivax schizons. You also see the female and the male gametocytes, where the male gametocytes stain lighter blue than the female. The infected erythrocytes tend to be enlarged in Vivax, as we've discussed already, and slightly enlarged in case of ovale. And these are the dots that they see, which they usually ask like second-year students, but it's not very important for us, I guess. Anyways, so Scuffner's dots are seen in Vivax. James dots are seen in ovale. Then Moros are seen in falciparum, and Zymats are seen in malaria. And we need to make a mnemonic out of it. The next is the age of the erythrocytes affected, which is extremely important because Vivax and ovale will affect only young RBCs. Malaria will affect only old RBCs, but falciparum will affect both. And this is another cause, another reason why falciparum is the most dangerous. Now, duration of the erythrocytic schizogony is 48 hours in all three except malaria, which is 72 hours. And hence, malaria caused by the others are known as tertiary fever or tertiary malaria, whereas that caused by malaria is called quartan fever or quartan malaria. Coming to the erythrocytic changes that take place in malaria, which is extremely important, and this is, I think, the basic understanding why falciparum is the most dangerous out of all. So, firstly, once the parasite has entered the RBC, and it will enter through specific surface antigens, as we discussed, it will cause membrane changes, which will lead to an irregular shape of the RBCs. It will make the RBCs more antigenic and less deformable. So automatically hemolysis increases in the spleen. Secondly, it will cause hemoglobin breakdown into heme, which is a toxic material, as we all know. So heme will be detoxified into hemozoin. And this is, it's not a malarial parasite, and sorry, it's a malarial pigment. So this is the pigmented color that you see on the peripheral blood smear. Now, what happens when this parasite is Plasmodium falciparum is that after 12 to 15 hours after invasion, you see these knobs that appear on the RBCs, and these knobs are nothing but at the PFEMP1 antigen, which is Plasmodium falciparum erythrocyte membrane adhesive protein. It's an antigen, and what it will do is, obviously it's saying it's adhesive protein, so it will adhere to the capillaries and the venules of specific vital organs. And for obviously, if it's a knob, it has to fit into something. So these receptors are like ICM1 in the brain, which is intercellular adhesion molecule, and chondroitin sulfate B in the placenta. So when this adherence takes place within the capillaries and the venules, which is the epithelium, obviously, epithelial lining of the capillaries and venules of the vital organs, this process is known as cytoadherence, which obviously leads to the blockage of these capillaries and venules. Cytoadherence, so that is first phenomenon. The second phenomenon is when the infected RBCs adhere to the non-infected RBCs to form rosettes. And the third phenomenon that occurs is the infected RBCs, they cluster themselves among themselves and they cause agglutination. So three processes of cytoadherence, rosette formation and agglutination will lead to complete blockage of the capillary and venules, and this process is known as the sequestration of the RBCs, which obviously are containing the mature forms of the parasite in vital organs. Now, when this sequestration takes place, it interferes with the microcirculatory flow and the metabolism of that vital organ, like the brain or the placenta or the spleen or the liver, etc. And the parasites, in fact, they continue to develop in the sequestered RBCs, and they continue to spread even further infection. So the principal host defense mechanism over here, which was that of splenic processing and filtration, it's not effective at all because all the parasites are in the brain. So no matter how much the spleen processes and filters the blood, it's not actually going to be effective. Similarly, on a peripheral blood smear, when you're going to draw blood, you will only see the younger trophozoite ring forms. And the level of peripheral parasitemia that you see actually on the microscope is going to be way lesser than what the actual number of parasites is within the body, because there are so many of them sequestered within vital organs, and you really can't see anything on the microscope. So this is the basic reason why falciparum is the most dangerous. Apart from this, obviously, we saw that there is decreased deformability of the uninfected RBCs, infected, yes, as well as the uninfected RBCs, leading to an overall decreased RBC lifespan. And so that was about falciparum. That was the most important. I hope you all have understood that. And the other three are benign malarias where there is no sequestration. You see all the stages on the peripheral blood smear. We've already discussed that Vivax and Ovale infect younger RBCs. Malaria infects the older RBCs. Usually parasitemia levels in them are lesser, like about less than 2%. But falciparum affects both, and it has very high parasitemia levels. Now, once this has happened, once the parasites have done this, how does the host respond? Firstly, it will activate the non-specific defense mechanisms. So the splenic clearance of both the infected and the uninfected RBCs takes place. It increases manifold. And suppose an RBC escapes, which is infected, then it is automatically destroyed when the schizon ruptures as the parasite grows and goes ahead with its life cycle. Now, when the schizon ruptures, it leads to release of materials that will activate macrophages and release cytokines. And these are in turn responsible for the regular fever spikes and rigors, which, as we see, are synchronized with the parasitic cycle, because we saw the erythrocytic cycle, which takes place in malaria is 72 hours, and for the other three are 48 hours. And this is with what your fever spikes and cycles will correspond, as we will see ahead. So I hope this so far is clear. This is the clinical part. Talking a little bit about epidemiology so that we have a basic idea. Basically, endemicity in case of malaria is defined in terms of the parasitemia rates, as we saw. What is the amount of parasite? I think I should just discuss it right now. So the parasite rate is the percentage of children between 2 to 10 years showing parasites in the blood. And why children? I'll just go through that right now. And the second is actionable spleen rate. See that. Now, but depending on whatever information is gathered, if the endemicity is less than 10%, it's 11 to 50%, 51 to 75, or more than 75. You divide any area into hypoendemic, mesoendemic, hyperendemic, or holoendemic. So people, or areas which are hypoendemic or which have less than 10% of transmission are called areas of unstable transmission, where there is low, erratic, and local transmission. It's not throughout the year. And hence, because the infection is not that common, full protective immunity is not acquired, and the disease is seen at all ages. All right. However, in such areas, epidemics may take place whenever there is a change in any of the factors. For example, if there is sudden rain after drought, especially in the months of July to November, where that is when we usually see malaria, especially in India, filling up of all the water, and this is a migration from non-malaria species to high transmission. Now, if there's migration of laborers, for example, on a high rate, non-malaria, they will not have any immunity. When they come to high transmission area, obviously, they will be an outbreak of malaria. So the important states of in India that have high transmission of malaria are the northeast. However, in the hyperendemic and the whole but we have what is known as a stable transmission, where there is a constant frequent year-round infection. So what happens? Infection is so common that people tend to become immunized as they grow older. So they get infected so many times, they will not have immunity. In young children, the seen is high, but most infections in adults are asymptomatic, and this is what is known as premonition. We'll come to that again ahead. And although we say that there is a constant frequent year-round infection, the disease prevalence might increase in rainy season. So I hope this is clear about unstable transmission and stable transmission, because a lot of points ahead are based on whether the disease is occurring in an unstable transmission or a stable transmission. The next is some people, as I said, especially in the high transmission or stable transmission areas, have resistance to plasmodium. So what are the basic mechanisms of resistance? The first thing is they can either be inherited alterations in the red cells. For example, if a person is heterozygous for a sickle cell trait, that is, then basically the oxygen concentration in the RBC is less and the parasites die. So although they will be infected with plasmodium, the incidence of death or the chances of so that is one. And hence we say that sickle cell trait is protective of malaria. The second is also and hence someone needs to mute this thing. All right. It's all right. Thank you. The next is if they have a repeated or prolonged exposure to Plasmodium, that is, suppose people are living in an endemic area, they gain partial immune-mediated resistance, like we saw in cases of stable transmission immunity. So it's called what is known as a premunation or a concomitant immunity. Active immunity is species specific. Now, basically, infants that are born to immune mothers, they are protected for the first 3 to 5 months because they have IgG antibodies in them. I think that is all that is important from this part. So endemicity is done. Now, talking about the measurement of malaria, coming back to that, we've discussed about spleen rate. No, we haven't. Okay, I think we'll see the clinical features and then we'll go to endemicity. All right. So basically, malaria starts first with non-specific symptoms like headache, which can be severe, but it will always be without neck stiffness or photophobia, which are mainly conditions of meningeal irritation. It can start with fatigue, abdominal discomfort, muscle aches, nausea, vomiting, etc. And then comes fever. Now, what we have studied typically is what is known as a classical malarial paroxysm, where paroxysm is nothing but an outbreak. Like literally, it means a sudden outburst of anything. So here we have a typical attack or a sudden outburst of fever. It's a fever attack which has 3 stages: the cold stage, hot stage, and the sweating stage. I don't know if you all can see clearly because I've written in pencil. The cold stage is the first stage, which lasts for about 15 minutes to 1 hour, where your temperature rises steeply from the normal temperature to about 40 to 41 degrees. There is severe headache, vomiting, and your pulse is rapid and weak. Now, initially, when you touch the patient, the skin will be cold, but later it becomes hot. Then you have the hot stage, which will last for about 2 to 6 hours with intense headache, nausea. The pulse is fuller now, and there is increased respiratory rate. But the skin over here is hot and dry. And the third stage is the sweating stage, which lasts for about 2 to 4 hours, and the patient has a slow pulse. Now, this is when the patient obviously sweats profusely, bringing down the temperature. The skin becomes cool and moist. Now, during the hot stage, which is when the temperature is the maximum, about 40 to 41 degrees, the patient might have febrile convulsions. And this is it's a warning signal, basically, which is suggestive of a falciparum infection, because it can also suggest what is known as a cerebral malaria, which is one of the complications and manifestations of a falciparum infection. So this is a typical attack, which, as we can see, is lasting for about, say, 1 hour of cold stage and about 2 to 3 hours of the hot stage, and then another 4 hours of the sweating stage for approximately 5 to 6 hours. And this attack, they occur with intermittent periodicity. So this is what is known as an intermittent fever, which is very classical of malaria. It's seen every 48 hours in Plasmodium vivax ovale. Ideally, we say falciparum also, and 72 hours in Plasmodium malaria. And hence we call it a quartan malaria because it's the only one showing it in 72 hours. However, what they say is, because we give treatment so promptly nowadays, we don't usually see this pattern at all. It's unusual. However, if it is occurring intermittently, then it is suggestive of vivax and ovale. But falciparum may never be this regular. So the fever spikes can never be very regular in falciparum. So that was about the fever. The other physical findings that you see in uncomplicated cases are anemia, especially in children which are staying in the stable transmission areas. That is because they are developing infection again and again. They might not show overt symptoms, but because of increased hemolysis and RBC distortion, they develop anemia, splenomegaly, and hepatomegaly with mild jaundice. Now, the important part over here is splenomegaly, because we are using this as a measure of malaria endemicity. We use what is known as a spleen rate. So a spleen rate is the number of palpable spleens or increased spleen rates between the age group of 2 to 9 years of children. Why we are not considering adults is because in adults there can be various other causes of splenomegaly as well. The average enlarged spleen is nothing but the same thing, but we're actually measuring what is the increase in the size of the spleen. So it's just a more refined method. Now, coming to manifestations of severe falciparum, I think I'll just take a slight pause here, and let me know if you all like want something. Like, is everything all right?
Yeah, everything is all right. You can go ahead.
All right. Starting with severe falciparum. Now, the first most important manifestation of a falciparum malaria is what is known as a cerebral malaria. Now, this is, we've already discussed the cause of this. It's because of the sequestration of infected RBCs inside the brain. So the first manifestation of cerebral malaria will obviously be coma, which can either be gradual or it can be sudden following a seizure. And it denotes a 20% death rate in adults. It's the most severe manifestation of falciparum. It can be a diffuse symmetrical encephalopathy where the eyes of the patient are divergent. There is a pout reflex or a snout reflex, which is nothing but if there's a damage to brain and you tap the lips tend to pout. It's a reflex and it's abnormal, so you won't find it in yourself or in me right now. And corneal reflexes are preserved, but if it's a deep coma, then even that, those are lost. Now, routine fundoscopy, this is very important. What are the fundoscopic findings in malaria? In 15% of the cases, you see retinal hemorrhages. You also see other abnormalities like discrete spots of retinal opacification. There is also discrete diffuse whitening of the retina. There is papilledema and cotton wool spots, which are fluffy white spots. If you want to see, this is a fundoscopy. You can see retinal spots and you can see the white fluffy snowball appearance, cotton wool spots on the retina. So I'm repeating, there are 4 important fundoscopic findings in malaria: retinal hemorrhages, diffuse whitening of the retina, then cotton wool spots, which are fluffy white spots, and papilledema, which is nothing but the edema of the area from where the nerve emerges. It's all because of nerve damage. Conversions are seen, as we saw, in about 10% of adults and 50% of the children, so it's more common in children. Now, the neurologic sequelae of cerebral malaria are mainly seen in children, especially the ones who have malaria along with hypoglycemia, anemia, seizures, or a deep coma. And the sequelae are usually hemiplegia, cerebral palsy, or blindness or impaired cognition, which usually these functions they restore in about 6 months. But overall, there is seen a persistent language deficit, and the children also have a decreased life expectancy. Apart from cerebral malaria, you can see hypoglycemia. And the reason for that is the liver, again, there is sequestration of RBCs in the liver. So there's failure of hepatic gluconeogenesis. And there's also increased glucose consumption by the host as well as the parasite. So that will lead to hypoglycemia. Apart from that, the drugs that we use for treatment, quinine or quinidine, both of them, they lead to increased insulin in the blood from the pancreas, especially in the pregnant females, which further adds up to hypoglycemia. And then, unfortunately, in this case, the typical signs that are sweating and tachycardia of hypoglycemia, they're not seen, and it may manifest extremely severely, leading to neurologic deficits. And it may become difficult to differentiate whether these neurologic deficits are because of cerebral malaria or they're because of hypoglycemia because of malaria. And hence, any form of hypoglycemia in malaria is a very poor prognosis. Similarly, because of the hypoglycemia and the hypermetabolic state, there takes place anaerobic glycolysis in the tissues. Apart from hypovolemia, there may also be renal impairment because of sequestration. All of this builds up to what is known as obviously lactic acidosis. And this further might lead to circulatory failure, respiratory arrest, and even death. And hence, acidosis is another very poor prognostic factor of a falciparum malaria disease. The next is obviously you can see non-cardiogenic pulmonary edema. And renal impairment, like we discussed, it causes acute tubular necrosis because the microcirculatory flow of the kidneys is impaired. And there can be hematologic abnormalities. We've already discussed that we see anemia. The reason being, firstly, there is accelerated RBC removal by the spleen. Secondly, when the parasite undergoes schizogony, obviously RBC destruction is taking place, and there is ineffective erythropoiesis in the kidneys, all leading to anemia. And we've already discussed because of in areas of stable transmission, as well as if the people are resistant to anti-malarial drugs. Next, we come to there may also be mild thrombocytopenia, which is another hematologic abnormality that you see. Liver dysfunction might also be seen, where you see all the, because it's like vital organ dysfunction, so there's also liver is also another vital organ. Now you see mild hemolytic jaundice, and it also contributes obviously to other, like we've already seen, it contributes to hypoglycemia because it can't carry out gluconeogenesis. It leads to lactic acidosis, and there's also impaired drug metabolism. So whatever drugs you give in malaria, they cannot be metabolized properly because there's liver dysfunction. What they've also said is HIV/AIDS predisposes to malaria, which seems pretty obvious. We've already seen about transfusion malaria. It may occur because of blood transfusion, needle stick injury, sharing of needles by the drug users, and organ transplantation. Whenever malaria is caused due to transfusion, it has a shorter incubation period. And radical chemotherapy with primoctin is unnecessary, as we've already discussed. Now, people who live in the endemic areas or people who have had malaria earlier, their blood is not accepted for 3 years for this reason, that the parasites actually remain alive and active in the blood during transfusion. Now, saying that during transfusion, they have a shorter incubation period, I thought of revising the incubation periods that we've already discussed for all the 4 species. So for falciparum, I've written it here, it's 12 days. I'm sorry. For vivax, it is 14 days. Malaria, it is 28 days. And ovale, it is 17 days. Going ahead, if you see a textbook like Baveja or some microbiome book, then they've used the word pernicious anemia, which is heavy basically it's just when there is heavy parasitemia. In case of falciparum, the various manifestations are cerebral malaria, algal malaria, and septicemia. So cerebral malaria obviously manifests as hyperpyrexia, coma, paralysis. We've all seen this. Algal malaria, you have cold, clammy skin because there is a disturbance in the peripheral blood circulation. And septicemic malaria, there is a high continuous fever along with organ enlargement. So there's multi-organ failure. They've also used the term black water fever. Basically, when a person is previously infected, but you've given them an inadequate dose of quinine, the parasites tend to reactivate, which is known as recrudescence. It leads to intravascular hemolysis, which is said to be because of an autoimmune mechanism. It leads to fever, and it leads to hemoglobinuria, which is why the name black water fever, because it leads to hemoglobinuria, which obviously leads to blackish color urine. Now, this gets us to the topic of relapse versus recrudescence, which was stressed quite a bit in microbiology last year. So relapse is what takes place in the hypnozoites, in Plasmodium vivax, and ovale infections in the liver, which we had discussed. And recrudescence takes place because of persistent drug-resistant parasites, usually seen in falciparum about 2 to 3 weeks after treatment. And malaria, they are said to be remaining in the blood for about 60 years, the parasites. And hence it may lead to recrudescence. So that was about the clinical features. Now we have clinical complications, but it is 11. So, and I have quite a bit to discuss. So do we want to discuss right now, or should we, I can have like a part 2 tomorrow maybe. Should we continue, it's only Aditi. So I'll do what Aditi asks me to do.
Can we continue the rest of it tomorrow, maybe?
Sure. Okay. Thank you so much for watching. Thank you all the people who had joined as well. I hope this was useful. I'll let you all know the time for tomorrow.
I'm sorry I kept my audio on in the middle, okay?
No, it's all right. Thank you. Bye.
Bye-bye.
Bye.